Good evening, friends. Once again, coming back to the ECG basics, the eighth session of the ECG basics, and today we will be talking about atrioventricular block. We commonly call it as a complete heart block. So, we will be next few minutes. I'll be talking about what are the types of AV block and how it manifests. How can we identify it and how we can manage it if there is going to be a discussion on it. So AV block is defined practically as a partial or complete interruption of impulses transmitting from the atrium to the ventricle. So it means the atrium is conducting. There is a sinus node is acting normally. Atrium is conducting. Conduction happens in the atrial musculature and reaches the atrial AV node. From there, it is not conducting properly to the ventricle. So this is what I have told. See here in the SA node, impulse activity happens and it innervates the atrium, both right and left atrium, reaches the AV node. From there, it has to go to the bundle of His, right bundle, left bundle, and into the Purkinje fibers for quick transmission. So this is the ECG correlation of this. From the atrium SA node, the P wave is the one which starts from there and it innervates both the atrium. So it takes two small squares, generally, two small squares for the atrium tract. Once the atrial depolarization happens, it reaches the ventricle AV node. So the AV node is a speed breaker. So AV node gets all the signals from both the atrium, acts as a speed breaker, processes the signal, then sends the signal down the bundle of His. So this speed breaker is around 2 to 3 small squares. That's all. This small speed breaker in the AV node is around 2 to 3 small squares. See, now you remember 2 small squares for P wave and 2 small squares for PR interrupt. That is the PR after the P wave. So it means that the AV node is acting as a speed breaker and something going wrong with it, there will be a conduction abnormality. Below which you have bundle of His, right bundle, left bundle, which will rapidly conduct. See, and it will see through that both the ventricles are inner musculature are innervated at almost at the same time. So that again the QRS complex, which is a large amount of musculature is innervated. Again, it is only two small complexes. See here, you are dealing with only two small complexes consistently. P wave 2, after the P wave, PR interval is only 2, and QRS complex are again two small boxes. So this is how the depolarization of atrium and ventricle happens. When atrial depolarization is merged with the P wave QRS complex, so we cannot see it, whereas the ventricular repolarization is seen as the T wave. Now you understand how it conduction system and the normal ECG and why AV nodal delay is very, very important. Sometimes it goes wrong, then we call it as AV conduction, AV partial or complete conduction abnormality, AV block or complete heart block. See here the same thing, P wave innervates, the P wave is there, and see the different color which is the innervation. The musculature which is happening and the speed breaker which is happening there is the P wave. After the P wave, there is a delay, AV nodal delay. Then you have a rapidly conducting wave, which is the third wave in the bundle of His and the right and left bundle. From there on, both the ventricles are conducted. Innervated depolarization happens. The QRS complex and the ST segment there. This repolarization gradually comes in where you have the ST segment, which is T wave, which is there causing the ventricular repolarization. And the cardiac cycle is complete by this. So you have got, now you know where exactly every wave stands. P wave in the atrium, PR in the distal part of the atrium and the AV node, QRS complex in the ventricle, and the relaxation part is seen in the T wave. Now I'm making it more and more clear because the AV nodal block is the one which we need to understand. So this is the area with which we are going to see. This one small segment of area which we are going to see. So now you know where exactly is the block and what is the block. So now we will see what is the types of AV block. So according to the relationship between the atrium and ventricle, we can detect 3 degrees of AV block. One is first degree AV block, second, third. First is all waves are conducted to the ventricles, but conducted with a delay, slowing of conduction. That's all. Second degree, there will be P wave is consistently present. Some of the P waves are not conducting, some are conducting. In third degree art block, there is no conduction happening. There is completely AV dissociation happening. Atrium and ventricles are dissociated. We'll see how we can identify. First degree AV block or PR interval prolongation is a disease, primarily a disease of the AV node. It is nothing to do with the lower conduction system, bundle of His primary disease of the AV node. So it is generally more than 5 small squares or 0.2 seconds or 200 milliseconds. So more than 5 small squares, whenever you see, it is called first degree AV block. See here, the cartoon clearly shows SA node is acting properly. In the AV node, there is a delay. There is a delay which is happening. So this delay is seen in the ECG as figure prolonged PR interval. Every P wave is followed by a QRS complex, but the PR interval is more than 5 small square. Here it is 7 small square. So more than 5 small square. Here it is 7 small square. 280 milliseconds is the PR interval. Now we are having a prolongation of the PR interval. This is first degree AV block. So ECG manifestation is very simple. More than 0.2 seconds or 200 milliseconds and more than 5 small squares. Every P wave will be followed by a QRS. It's nothing is dropped. Every P wave is followed by a small square, PR inter QRS complex, and it is regular. The most of the time, the first degree AV block happens in the AV node. Primarily, we see it in inferior wall MI. Commonly, there is a particular time, and the elderly population where there is a degenerative conduction system happening. And in acute condition like myocarditis and electrolyte abnormalities, you can see it. And the common cause in our practice is medications, AV nodal blocking medication, like a beta blocker, a calcium channel blocker like diltiazem or verapamil or digoxin can cause it. So these are the medication which can cause AV nodal delay, and the first degree AV block can be there. So here it is very clear. P wave is normal, PR interval is prolonged, and QRS complex is normal. So now you understand first degree AV block. Usually suspect medication, look for medication error. If it is not there, possible in elderly age degenerative, in acute MI situation, likely that we are dealing with inferior postural MI with complete heart block. Right? So moving on to the second degree AV block, the next higher grade block. First grade, every time the P wave is conducting with a delay. Something is there, but it is conducting with a delay. It is not working well. Whereas in second degree AV block, Mobitz type 1 and type 2 types are there. So here, something is conducting, something is not conducting. Because AV node is diseased or bundle of this is diseased. So it is something is conducting, something is not conducting. We'll see how. See, second degree AV block, it is predominantly, it is in the AV node, type 1. Mobitz type 1 we call it is predominantly in the AV node. What happens is AV node is diseased, but not completely diseased. So what happens is, so conduction through the AV node happens, but the first conduction comes and knocks, AV node allows. The subsequent conduction comes and knocks, AV node is not ready. So it conducts with a delay. The third conduction, sometimes it is not still ready, it is further prolonging. And fourth conduction, it is not at all ready, so it is not conducting at all. So it is not recovered. AV node, because of the disease, it is not recovered. That's all. See here, there is a PR interval. First conduction conducts normally. Second conduction, there is a PR prolongation. Third conduction, there is further prolongation because it is diseased, though it is not allowing. It is not recovering properly for the next visit. So it is like a concussion injury where you are not recovering properly. So it is, see the next beat, the P wave is not at all followed by a QRS. Completely it is dropped because the AV node is diseased. It cannot further allow the P wave conduction to happen across the AV node. So it is completely blocked. Then again the next cycle starts. See here, next cycle is the normal PR interval. See here, the first PR interval normal, prolongation of the PR interval, further prolongation, and it is a drop. So now you call it as Mobitz type 1, Venki back phenomenon. Now you know, understand Venki back. Here again, most of the time I see it in the inferior wall MI. So Venki back phenomenon. So constant, P wave is constant. It comes at the same place. Whereas QRS complex is progressively, PR interval is progressively increases. That's the reason why there is a drop after a period of time, because AV node is diseased. This is called Venki back phenomenon. PR interval prolongs with each beat until a drop beat is seen. The PR interval is not constant, it is progressive prolongation. After each drop beat, the PR interval is normal and the cycle starts again. So after 3 or 4 beats, one drop beat will be there and the cycle starts again. So second degree type 2 AV block, that is Mobitz type 2 AV block we'll see. This is the prolongation of PR. This is the type 1 where Venki backing happen. See here the PR interval, it is further prolonging, and it is not conducting, drop beat. So if this is all pattern recognition only, a very simple thing. You see the pattern, PR prolongation, further prolong, and a drop beat, you call it as Venki back or type 1 second degree AV block. Most of the time you are seeing in inferior wall myocardial infarction, and obviously, of course, the drug and cardiomyopathy, rheumatic fever, and electrolyte abnormalities. Coming to the second degree AV block. Second degree AV block could be either in the AV node or in the infragicial, bundle of His or infragicial. So there could be anywhere in the conduction system from the AV node to the bundle of His. We can see it from the bundle of His. So this type of block occurs below the AV node at the level of His bundle. It's also not functioning properly, like AV node, Mobitz type 1, it is also type 2 also not functioning properly. So sometimes it conducts, sometimes it's not conducting. See here, the P wave followed by a QRS complex. One P wave is not conducting, it is not conducting, then you are having a P wave QRS complex. P wave is conducting, not conducting, then again conducting. So it means some of them are conducting and some of them are not conducting. So it means there is a intermittent loss of conduction from the atrium and ventricle. But atrium during conduction, it is normal. There is a P wave followed by QRS complex. So there is no disconnect. There is a AV association is there. There is no disconnection. But during conduction, it is normal, whereas sometimes it misses the conduction. So conduction through the AV node is constant. PR interval is normal. The point is here, Mobitz type 1 PR interval is prolonging. Here, PR interval is normal. Whenever it is conducting, it is normal and is constant. And on and off, that is the drop beat. PR is not, P wave is not followed. See here, P wave, PR interval normal. After that, you expect a P followed by a PR interval, P wave. You expect a QRS complex here. It is not happening. That is completely dropped. Then you have a P wave with followed by a QRS complex. So intermittent loss of conduction predominantly happening in the below the AV node in the His bundle or infragicial area. You call it as second degree heart block or Mobitz type 2 block. Now you understand. Mobitz type 1 is much more friendly to us. It is not so much pathological. Usually it is reversible. Whereas here, infragicial means the patient has got a dangerous problem. Intermittent conduction, loss of conduction can progress to complete loss of conduction very quickly. So this is an urgency for that as far as rhythm is concerned. So now this, how do you manage this? So because it is an urgency, the infragicial, whenever when it is completely lost, means the patient can, ventricle starts taking its own course and it can start producing impulse of its own, and ventricular tachycardia can be there, or very slow ventricular rhythm can happen and patient can have syncope. This is what can called a stroke syndrome attack, and the patient can have complete heart block in future very quickly. So it requires a permanent pacemaker implantation. What you require to document is PR interval is constant and you are having a non-conducted P wave. That's all for second degree wave block. Whereas in type 1, if Mobitz type 1, Benke backing phenomenon, PR interval is progressively prolonging and there is a dropping. Here, PR interval is constant and there is a dropping. In third degree heart block, it means complete heart block. There is nothing is there. Completely atrium is conducting, P wave is normal, but the ventricle is not able to get the impulse from the atrium because the atrium, AV node or the bundle of His is failing to conduct. It is not working well. So complete failure of the AV node. No impulses from the sinus node will pass through to the ventricle, and some part of the conduction system will take over as the pacemaker of the heart. So whenever there is something in the bundle of His, that means it can have a narrow QR. After that, there is a right and left bundle can be conducting. So that means the rate will be around 45 to 60. And the QRS complex, because the conduction system, through the conduction system is happening, QRS complex will be narrow. But when it is getting lower down, close to the ventricle, the escape rhythm will be less than 40, 30, 35. That is also will be unstable. So it is like a students in a classroom without a teacher, because any part of the ventricle can be a pacemaker and it can regularly conduct and can go for a ventricular tachycardia and ventricular fibrillation and death. So complete heart block is dangerous, especially when there is a escape rhythm is wide QRS complex. So complete AV block, third degree AV block, characterized by atrioventricular dissociation. Atrium is not associated because P wave is beating separately, QRS complex beating separately. The blockage is infranodal. It means AV below the AV node. It can be due to bilateral bundle branch block in this bundle of his atrium ventricular activities are unrelated. It is not related because atrium beats at a faster rate of more than 60 to 100 like that, whereas your infragation escape can be 30, 35, 40. So there is no association between atrium and ventricle. So whichever the dominant can take charge. Here, you have to see whether there is a AV association. So how do you want to see? Dissociation between P wave and QR. That is the salient hallmark of complete heart block. In the type 2, there was intermittent loss. Here, there will be consistently, there will be, see here, there is a P wave. Here, the QRS complex morphology is altered. See here, the QRS is here. But distally, there is a alteration morphology. This is the P wave. Okay, it is not there here. See here, it is the P wave is not, QRS complex is different here. This is the P wave. This is the P wave. So it is consistently coming at every 4 squares once. Here it should come because it is the QRS complex larger, it is not happening. So it is submerged within the QRS complex. Again it is coming, again it is coming, again it is coming. So even though this appears to QRS complex following a P wave, but rest of the P waves are not associated. I mean, this is also not associated. There is a complete AV dissociation. So whenever there is a wide QRS, heart rate will be less than 40, which is dangerous. These are the people who can have syncope and come to the hospital. So complete third degree AV block, P wave rate is normal, 70, 80, 90 like that. Ventricular rate is very, very slow, 30, 40. So if a complex will not have preceded by a QRS P wave, the atrium and ventricle is not associated. We have got a complete dissociation of the P wave and the QRS complex. So now you can see here, the P wave here, the P wave here, P wave, and the QRS complex in between is happening. So QRS complex is happening at a different rate, P wave is happening at a different rate, atrium is happening at a different rate, and ventricle is happening at a different rate. Because both of them are not simultaneously acting, we call it as atrioventricular dissociation. Now you understand why you call it as atrioventricular dissociation, because atrium and ventricle are acting in a different way. Now you understand what are the degrees of heart block. So there are 3 degrees of AV block. First degree AV block, all P waves are conducted to the to the ventricle. QRS complex is there, but conducted with a delay. PR interval is prolonged, more than 200 milliseconds or 5 small squares or 0.2 seconds. Whereas in Mobitz type 1 second degree AV block, there is progressive prolongation of PR interval. First PR interval is normal, means second will be more prolonged, third will be more prolonged, and fourth will be lost. P wave will not conduct again. So that QRS complex will be dropped. In type 2 second degree AV block, that is Mobitz type 2, you have consistent P QRS complex with normal PR interval. PR interval is normal. Suddenly you find one P wave is not conducting. This is dangerous because it is an imminent complete AV block. The complete AV block is the picture like this, where P wave is consistently beating at a higher rate, whereas QRS complex is beating at a slower rate. So you will have a complete AV dissociation, which is again is dangerous. You require pacemaker. Type 2 second degree AV block and type 3 AV block, you require permanent pacemaker implantation. Type 1, Mobitz type 1 AV block, we can wait and watch most of the time. It is reversible and you can patient can become normal with the correction of the primary problem. Type first degree AV block as well, we can wait and watch unless there is a patient has got a irreversible disorder, degenerated conduct system, where we require to watch them completely. Right? You understood complete AV block. Thanks for watching. If you have doubt, I will stop sharing. We can discuss whatever the doubts you have. You can unmute yourself and you can ask your doubts.
For 6 sinus syndrome, bradycardia vara vaipu irukku sir. 6 sinus syndrome.
6 sinus syndrome, entity completely encompassing sinus node, AV node, a bundle of his, and all the deconduction system. Even though we call it a 6 sinus syndrome, this is a complete degeneration of the sinus node, AV node, the bundle of this and this bundle. That is the reason why anything can happen in 6 sinus syndrome. Not only sinus impulses will be absent or conducted with a delay, AV nodal delay can also be there, sir.
It mimics like first degree or second degree.
Anything can happen. Anything can happen with 6 sinus syndrome because it is a purely a conduction system abnormality, where it either SA node, AV node, bundle of this, anywhere there will be a conduction abnormality which can cause problems, sir.
Good evening, sir. Sir, in case of Mobitz type 2 and type 3, like once patient comes to us with syncope or the patient has syncope in front of us, what are we to do in the periphery, sir?
Sir, it is very, very difficult question to answer because there are no medication. Your atropine, everything will not work. Your RC proline tablet also will not work because most of the time it is a degenerative complete heart block or degeneration. So you are trying to, by giving atropine, you are trying to stimulate SA node predominantly. What happens in the to stimulate SA node? More PVF happens, and more you are bombarding the deceased AV node or infragestion block. What happened? It is very further they will not conduct because already it is diseased. It is not able to conduct. You are accelerating the bombardment that will not conduct, and you are giving RC proline tablet also will not help because nothing is going to help. It is a degenerative disease. So whenever you see it, only way out to helping is put a temporary pacemaker and plan for permanent pacemaker implantation. For that, you require to send the patient to a tertiary care center. Only thing is the warning. So there are multiple times I have seen people injecting atropine and sending the patient, but it's not going to work. Sometimes atropine or other things because of the vagolytic action, more sympathetic activity can happen, and ventricular tachycardia can also be triggered. So do avoid giving all this injection because it's not going to work. It's not going to help as well. But only thing, quick medical attention. With fortune, the patient should reach a center where pacemaker is being implanted.
Okay.
Sir, when the heart rate comes, the ventricular idiopathic rhythm also will stop. How to find this third degree block and idioventricular?
Obviously, sir, third degree, sir, third degree AV block vanduduna, it can be there in the AV node deceased or infrahisian, that is bundle of his or SA, right bundle or left bundle deceased. It means that the conduction cannot, the sinus node impulse cannot pass through that area. So the patient ventricle, because without that ventricle should contract and eject blood. That's for the patient to live. So that the patient for heart to contract, the ventricle starts taking charge as a pacemaker by itself. So that's the reason why it has ventricular escape rhythm. But unfortunately, any part of the ventricular wall can have this escape rhythm. So it means multiple escape rhythm can happen at the same time, and patient can land in ventricular tachycardia and ventricular fibrillation and die of it. So that we should not allow this ventricular rhythm to happen for a long time. So we have to immediately try and solve this problem. Solution, there is no medication. Here it is only purely a conduction degenerative abnormality which can be addressed only by a pacemaker, not with medication.
So the only solution is immediate referent and
temporarily
is pacemaker, then permanent.
No medication is going to work. Even though I find a lot of cardiacs also trying to give oxypronaline, everything, but degenerative disease is not going. You are replacing the conduction cell with a fibrous tissues. So these fibrous tissues will not conduct at all. It will not act. We have no medication. Pharmacology action will not happen.
So during the transport of the patient,
you need not give any medication. Only thing, prime them for pacemaker. Whereas it's a different story when there is going to be a inferior wall MI. See, inferior wall MI, the disease is transient. It is ischemic. So AV node is working. It is ischemic. So you try and stimulate some conduction until the patient reaches the specialized center. So at that point of time, giving atropine and everything can work, but not with a stable patient with a syncope coming with a second degree Mobitz type 2 is a block or complete heart block. That is not going to work.
So reference with to avoid the postural hypertension.
Avoid death also.
Yes. Okay. Thank you, sir. Thank you, sir.
Thank you, sir.
Good evening, sir. Sir, one doubt, sir.
Solunga.
Sir, first degree, second degree, third degree heart block, how to calculate the heart rate, sir?
Sir, it is the same thing. But the basic principle is that either you have to have a 300 divided by bigger number of big squares or 1500 divided by small square. That's all. Anywhere it is, whenever there is going to be a third degree AV block, calculate the ventricular rate and tell it this is the pulse rate. Because atrial rate will not contribute to the pulse rate. So calculate the ventricular rate, the QRS complex, and take it as a pulse rate. Whereas in first degree AV block and second degree AV block, something is conducted, something is not conducted. So that you can assume that the pulse rate will be equal to the P wave and QRS complex.
Okay, thank you.
Thank you, sir. Thank you very much.
Thank you.
Nice.
Much.
Bye, sir.
Bye. If there is no question, I will wind up with this. Thank you very much.
We are very proud of you, sir. Very perfectly, clearly we are explaining.
Thank you. Thank you very much, sir. Thank you.
Thank you, sir.